everyone, and welcome back to another insightful episode of MedSynapse podcast series, where we bring you expert insights to advance your clinical practice. I'm your host, Hetvi Shah, and today we delve into kidney cancers from detection to management. And joining me is Dr. Aditya Parikh, a highly trained uro-oncologist and robotic surgeon from Ahmedabad. Dr. Aditya has a fellowship in pelvic uro-oncology and robotic surgery from UCLH in London, PRNB in urology from MPUH in Nadia. He specializes in early detection, prevention, and advanced robotic surgeries for urological cancers, ensuring minimally invasive treatment and improved outcomes. So, Doctor, welcome to the series, and it's a pleasure to have this conversation with you.
Thank you very much, and it's an absolute pleasure for me as well to be on this platform. Thank you for the invitation, and thank you for doing this series because I think continuous medical education for doctors, knowing about other specialties is extremely important as it broadens our horizons and enables us to give quality care to our patients.
Definitely, that's so rightly said by you, Doctor. Doctor, to start with the rising incidental detection of small renal masses due to widespread imaging, what is your current approach towards active surveillance versus intervention for these cases?
Great question. And firstly, it is very good that we are now detecting renal masses incidentally, because back in the day, the renal masses used to be detected when patients had pain, hematuria, or some sort of metastatic deposit in the lung causing breathlessness. At that stage, it is very difficult to treat kidney cancer. The outcomes are not as good. But when renal masses are incidentally detected and they are small in size, the treatment for those is so good that we can almost ensure that most patients are alive at the 5-year or 10-year mark. Especially when tumors are detected as small renal masses. That's when the role of something like active surveillance comes in. So active surveillance is basically that you watch the renal mass because some of these masses are very slow growing and they don't progress. It is an excellent form of treatment for those who are having multiple comorbidities. Say somebody is in their 80s, has undergone an abdominal ultrasound for some abdominal pain or discomfort and incidentally found to have a renal mass which is not symptomatic, which is about 2 or 3 centimeters in size, then it might be unwise to treat that person if they have, say, undergone a bypass surgery, have multiple comorbidities, have diabetes which is uncontrolled. When the renal mass is unlikely to take their life or cause any metastatic problems, it is unwise to treat those patients. Contrary to that, age is just a number. So if you have an 80-year-old with a 3 centimeter mass and that person is extremely fit, then that person is eligible for undergoing standard treatment, which could be a partial nephrectomy or a radical nephrectomy, depending on the oncological appropriateness, as I would say.
Yeah, so I think identifying those masses according to your age and various factors is also necessary, right?
Correct. So it is basically personalizing our care and ensuring that the right patient gets the right kind of treatment. Active surveillance is excellent for older comorbid patients with small renal masses, and we've been practicing it for a while. When I was in the UK, it is a very common form of treatment that is conveyed to the patient, and the patient is given that option.
Correct, yes. So now, doctor, there has been a significant shift towards nephron-sparing surgery. So could you share your perspective on partial nephrectomy versus radical nephrectomy for T1B and selected T2 tumors?
Correct. So as you rightly pointed out, with both the advent of minimally invasive robotic surgery especially, most renal masses can now undergo partial nephrectomy from a technical standpoint. So technically, it is possible to do partial nephrectomy in most of the renal masses. However, oncological appropriateness also has to be considered. As I said, the treatment should always be personalized. It is not every T1B or T2 is the same as the other T1B or T2. So even if it is a T2, say it is a lower polar T2, in a young person who doesn't have too many other comorbidities, it is very clear that it is a well circumscribed tumor which is not invading the sinus or going into the perinephric fat, then for that kind of patient, it is a good option. So oncologically, when it is a T2 which can undergo a partial nephrectomy, leaving behind enough volume of kidney for it to give the patient good GFR, that is when one could do a partial nephrectomy for a T2 lesion. For T1Bs, absolutely it is a good option and it can be very safely done in most of the situations. However, as I said, it depends on the patient's profile. You have a 76-year-old with a zero point 0.8 creatinine, multiple comorbidities, and an 8 centimeter lower molar mass. That person basically, in my opinion, should undergo a radical nephrectomy rather than a partial nephrectomy, because you're not trying to only spare nephrons at the cost of oncological compromise or do a complex operation which is more prone to complications in a person who has that kind of profile. So it is not just the stage, but also the overall condition of the patient that dictates what sort of treatment they should undergo.
Yeah, I think that's rightly mentioned by you that overall lot of various factors also come into picture. So
Absolutely,
now,
absolutely. But
doctor,
from the oncological standpoint,
hmm,
happy to do a partial nephrectomy in patients who are eligible for it for both T1Bs as well as T2 tumors.
okay, perfect. So now, doctor, in patients with oligometastatic disease, how do you decide between systematic therapy alone versus combining it with metastasectomy or local ablative therapies?
Correct. Excellent question. So whenever somebody is identified with metastasis, it is important to risk stratify them. So
Mm.
patients will fall either into a good risk, intermediate risk, or a poor risk stratification. For those in the poor risk, uh, ablative therapies or surgical treatment may not ideally be very suitable. However, when there are resectable metastases or metastases that can be ablated by things like SABR, which is stereotactic ablative radiotherapy, those kind of patients in the good risk or the intermediate risk should have a combination of surgical treatment, ablative treatment, and systemic treatment. And we have excellent systemic treatments now. Very often now what we do is patients start with the systemic treatment, we assess the response, we identify the responders, and in patients who are responding well to the systemic treatment, we then go ahead and do a cytoreductive nephrectomy with ablation of the metastasis. So that is a good sequencing of all the tools that we have available at our disposal for treating oligometastatic kidney cancer.
Correct. I think that is so important to consider also. So now, Dr. How do you approach surveillance and follow-up in patients post-treatment for kidney cancer to ensure early detection or recurrence?
Correct. Very nice question and very important
Very
because
important.
nothing ends at surgery. So
Mm.
it is a cancer that is liable or prone to coming back. So follow-ups are very important. Again, as we do in most things in oncology, we risk stratify uh, patients into categories of low, medium, and high risk for recurrence. And those people who are at a low risk, we initially do CTs at 6 monthly intervals, maybe follow them up of up to 5 years. Those in the intermediate risk, we might do sooner, earlier scans, follow them up at least for about 10 years. And those in the high risk, we would follow them for a lifetime. Initial scans would be at about 3 monthly intervals, then 6 monthly intervals till about 1.5 years. Then we could make those scans maybe annual, and then we follow them up with annual lifelong scans.
Okay. Okay. So that's like a long process, but it is also very necessary, right?
Absolutely,
Like
absolutely. Because now if
post-treatment
we
is
identify
really.
recurrence or metastasis,
Mm.
especially say for example we have done a radical nephrectomy for high risk kidney cancer, then now there is a concept of giving adjuvant treatment as well for patients who are likely to recur. So we have excellent immunotherapy like pembrolizumab. So the recommendation is to give pembrolizumab for 1 year in patients who fall in this high risk category, and
Mm-hmm.
that has decreased the chance of recurrence, given patients better overall survival.
Okay, that's quite insightful, Doctor. So now, doctor, what are the current updates in systematic therapies for advanced or metastatic kidney cancer that every oncologist should know? I think you just started that answer.
Correct. So, the entire landscape of treating metastatic kidney cancer has changed over the last
Hmm.
decade. Initially, we were limited to sunitinib or sorafenib, medicines that did not have the kind of response we wanted. And even though some patients did have response, they were very toxic. So it was very difficult to manage those patients with either recurrence of metastasis or metastasis. When we deal with metastatic kidney cancer, we work very closely with our medical oncology colleagues. So, currently, the standard of care for kidney cancer, which is metastatic or has recurred, is to give a combination of IO and TKI, which is immunotherapies and tyrosine kinase inhibitors. So IO-TKI combinations or IO-IO combinations, depending again on the risk stratification, have become standard of care. So you start with one combination of IO-IO or IO-TKI, depending on which risk the patient falls into. These medicines are namely, ipilimumab, nivolumab, axitinib, pembrolizumab, or various other molecules that are now available. So you risk stratify, you start with one combination, see how the patient does. A lot of patients do very well. And when they recur, you move on to another second line of treatment. So then in that category, we often have medicines like lenvatinib, etc. So there's a bunch of medicines available. They are still fairly expensive in our country. So an immunotherapy cycle can be very expensive for the patients to undergo. However, that said, it is a lot of patients get complete response, which is called CR in medical jargon. So we have seen patients who back in the day we would have given up on responding very well to these treatments and living normal, good quality of life. Thankfully, these patents are going to expire in the next few years, and we'll have more and more of these immunotherapies available at a more reasonable price for patients of our country.
Yeah, I think that's rightly mentioned, and it has changed over a decade. So the next decade would be more promising, I would say.
Absolutely, absolutely. So there are some young patients in literature we have discussed with our colleagues from across the world who have been diagnosed with metastatic kidney cancer in 2013, and then one after the other, new molecules have been used on them, and they're still doing very well.
Oh, that's so good to hear also
Yeah,
sometimes.
yeah.
So now, doctor, finally, and I think this is one of my favorite questions to each doctor that I speak to. What is
Yeah.
your key message for general physicians and urologists to ensure early diagnosis and optimal referral for kidney cancer in patients?
Correct. So this is what I always say, that if there is one take home from this entire discussion
Mm.
that we have had, is that get a screening USG abdomen and pelvis for everybody beyond the age of 40 at least, and a serum PSA as a screening PSA for all your male patients who are 50 or more, and 45 or more when they have a strong history of prostate cancer. So, from a early detection standpoint, from uro-oncology, these two tests are very important. You could do urine routine microscopies as an adjunct, but in our country, to get an abdominal sonography is so easy. It can pick up diseases early in my family as well. I have seen incidental renal masses getting picked up at 2.5 centimeters in size, getting treated, and people doing very well. So early detection is key in all cancers, and that stands true for our urological cancers, especially kidney cancer, because at the end of the day, biology is king in oncology. And no matter how much we advance, the sooner we pick up disease, the earlier the stage, the better the outcome is, the less invasive our treatment modalities can be, and the better our patients will do. So that is my key message to all general physicians and oncologists, that please make sure that you offer this to your patients and to your family members. And now a lot of things are possible within uro-oncology. So if you do find patients with these diseases, be quick to refer them, and they'll have excellent outcome.
Yeah, I think that there was such a valuable advice for all the healthcare professionals out there, doctors. So, Doctor, as we wrap up today's session, thank you so much for these valuable insights on kidney cancers. And I'm sure that our listeners will benefit immensely with this conversation today.
Thank you very much. It was an absolute pleasure. I had a wonderful time discussing this very important topic close to my heart. And thank you for to the audience for tuning in and listening. Thank you.
Thank you, Doctor. And to all our HCP listeners, remember if you're a healthcare professional who's eager to delve deeper into medical topics or have questions, do not hesitate to join us on the MedSynapse platform. MedSynapse platform is not just a resource, it's a dynamic space where you can connect with your medical peers, participate in meaningful discussions, and contribute to the ongoing evolution of healthcare. So until next time, stay tuned and take care of your health.